Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi everyone, thanks for listening in to this podcast by the Liver Foundation. I am Dr. Margaret Ting. I'm from the National University Health System in Singapore, and I have with me today, I'm really excited and privileged to have with us today Professor Bajaj. He's a professor of medicine from the Virginia Commonwealth University, and he's also at the Richmond VA Medical Center. So welcome, Professor Bajaj, and thanks a lot for taking the time to talk to us today. Today we will be discussing a recent article that he led on behalf of the CLEARED Consortium. This is titled Global Disparities in Mortality and Liver Transplantation in Hospitalized Patients with Cirrhosis, a prospective cohort study for the CLEARED Consortium, and this was published in the Lancet Gastroenterology and Hepatology. So welcome once again, and thank you for agreeing to this interview, Professor Bajaj. If I may
Thank you, Dr. Teng.
Yeah,
Thank
if
you,
I may
Dr. Teng,
just,
for this.
Yes, thanks a lot. If I may just start the ball rolling, maybe we can establish a kind of background to this article. What is the epidemiology in terms of the global and regional mortality from cirrhosis?
Yeah, so the reason for this consortium was basically, if you know, the definitions of acute and chronic liver failure or in patients with cirrhosis are very siloed. Every part of the world has their own definitions, and it's very difficult for us to crosstalk with each other. So the group got together, the people in the CLEARED Consortium, and said, okay, let's go back to the drawing board and say, what actually does determine who lives and who dies in centers across the world? And this not just few centers like, people in Delhi or people in the United States or people in Europe or people in, the developed part of Asia, but we want to make sure that there's adequate representation throughout everywhere. And therefore, we wanted to make sure that every center only had 50 per site, 50 patients per site. So it would not really end up being one site predominant, depending on how good someone's research machinery is and how quick they are to go. But we wanted it to be represented. So this was more of a back to the drawing board to see what actually predisposes people with cirrhosis who are admitted across the world to live or to die either during the hospitalization or 30 days. And therefore, we wanted a globally representative population. And we also thank the National University of Singapore, who's also one of the sites here in this study. So we have participation from every continent that is populated, and we are trying to get more and more people enrolled in this so that we can get a better option, so that some of the definitions that are made in silos where everything is available to the patient may not be applicable to places that are not as developed, or in people who don't have insurance coverages, even in those centers that are very well developed. So that was the background of us putting this consortium together and trying to, it's basically to raise awareness that not every single person lives in either, developed parts of Europe, developed parts of North America, or developed parts of Asia. There's huge amounts of people that are suffering from liver disease that need help and need more resources elsewhere.
Thanks a lot for, I guess, shedding some light into the background behind this study. So maybe you could comment. I mean, you mentioned that this is a multi-center, multi-country, multi-region study. How many regions do you manage to recruit from, and how many centers from each region would you say?
We had more than 120 centers, and some centers, unfortunately, were not able to enroll as many as the others. But there were more than 3,800 patients that was published in this paper. But right now, we have more than 5,000 patients enrolled. After this paper, things have, continued to stroll along. And they are throughout every center that you can possibly think of. Centers that don't have liver transplant, centers that are leading in liver transplant, centers ranging all the way from beginning to the end. We have every center expertise. And in fact, some of these centers were the first time we had actually even enrolled any patients from there in like a largest trial. So it was a very humbling and a very rewarding experience as well, to make sure that we took everyone with us. But for the paper that you point out that was published in Lancet Gastroenterology, we had more than 3,800 patients, majority of whom were from upper middle income countries. So 1,757 and 1,400 were from high income countries. And we had to mix the lower and lower middle income countries together, which around 18% were from there. And what we found is that 8% of people died in the high income countries, 10% in the upper middle class, and 22% in the lower and lower middle income countries. And this was a big surprise, not a complete shock, but still a surprise to see it so starkly in black and white, that these are disparities that persist despite us controlling for the MELD score, despite us controlling for every single thing that you and I as liver disease doctors or people in the ICU or people in the inpatient setting would control for. This really was people coming in later because they could not now afford to stay out of the hospital, or the hospitals not having resources to provide to the patient, or the patient not being able to afford resources that were available to them in case they were there. An interesting wrinkle was that some medications are available in some parts of the world, and some medications are not, and some medications are quite expensive. For example, you would assume that USA and Canada, very well developed countries, but we don't have access to terlipressin, at least at that time, whereas the rest of the world did. So it's kind of the reverse disparity that you would expect. Same with rifaximin is very expensive in the United States and Canada, where it is not as expensive in some parts of the world, such as, India. So it doesn't always work in the way that you would expect it to work. There are disparities in both directions. So it was important for us to actually make a much more granular study rather than, take databases and go from there. That's why we insisted that every patient get a consent form. Every site, you go deep into the patient's chart, talk to them and see about their ability to afford and things like that.
Yeah, so I think that is you brought up a very good point actually. I think you mentioned, I think the key message of the study was that patients with cirrhosis from higher income countries seem to tend to do better in terms of clinical outcomes. And actually, it's quite interesting to see that the patients in higher income countries, they seem to have like more complications at the baseline. Like if you look at the at baseline, they look like they had more previous hospitalizations and history of hepatic encephalopathy, ascites, etc. And yet, on admission, the ones with the higher MEL scores would be those in the lower income countries. Could you perhaps like comment on these kind of unexpected, I wouldn't say unexpected, but this kind of study findings? Yeah.
Yeah, this is a very important point that you brought up. And even though we studied a snapshot in that patient's history, which is the inpatient hospitalization, this is all builds up from how the patient was taken care of before versus how they were going to be taken care of after they were discharged. So someone with multiple episodes of hepatic encephalopathy presumably was on treatment for that, even though their MELD score was much higher, they had 30-day outcomes. Also tended to have 30-day rehospitalizations because they could. Whereas some people, we assume, in the people with lower resources, had to wait until their liver disease became so severe that they had no choice but to, stop their daily job or whatever job they were doing that they couldn't afford to do before, couldn't afford to stop before, and had to come to the hospital. And once they were discharged, they were either not able to come back to the hospital, or they unfortunately passed away, or they did not have access to liver transplant. So even though we focused on this one snapshot in this patient's natural history, it really tells a whole story, like you brought up, that despite having a much worse clinical profile in the high income countries, if you had access to all these resources before and after the hospitalization, you would do much better than someone in whom this might be their first episode of, say, suppose, varicose bleed, or first episode of hepatic encephalopathy, or first episode of hepatocellular cancer in some sites in which either the patient or the sites are not fully resourced.
And I guess this leads on to one of the other findings in the study, which I think you also kind of explained in the discussion, in that those from higher income countries, actually they had higher readmission rate. I mean, if you would expect, if they had access to all these great linkage to care outpatient in the community, and they were optimized in terms of care of cirrhosis, perhaps that would have prevented readmissions. Could you maybe kind of explain this to our listeners again?
Yeah, the readmissions are a double-edged sword. So if you look at, it's the preventable readmissions that we worry about. And who decides whether readmission is preventable or not? There is no gold standard. So readmission, just the fact that someone is paying enough attention to you to think, or you or your family member or someone is actually paying that much attention to you, that they ring the alarm that now is the time for something to happen to manage this patient, because ultimately readmission is not really a failure of the system. Readmission is to make sure that someone actually ends up getting the care that they need to get, that is just not available to them in the community in that particular circumstance. In fact, some studies have actually shown that if you get admitted earlier, some of them have a better prognosis, of course, because it's better to have 1 or 2 days of hepatic encephalopathy related admission where things are tuned up, rather than 7-8 days where you end up getting a fall or getting grade 4 encephalopathy. But this is very individualized. So we have started looking at readmissions as a measure of how responsive the system is to your needs once you're discharged from the hospital. Of course, what you bring up is a very important point as well, is maybe these patients were discharged sooner than they would have in the index hospitalization. But there, as you and I know, there are some conditions that you just cannot predict and that have to be managed in the hospital, that whatever resources you put at that patient, they will be non-preventable. So the readmissions as a whole may not be that big of a ding to the system, but preventable readmissions, which we unfortunately did not have the chance to go and figure out, may be an issue that we need to all get resolved a little bit better.
And as just a kind of like question, I guess, on the study and also the consortium work, was there any reason why you picked the 30 days post discharge as one of the outcomes studied? Why not like 90 days, or even looking at the longer term outcomes in terms of like 1-year mortality? Is that something that the consortium is looking at as well?
So some sites were given the option of doing 90 days and 30 days. This was an unpaid consortium, so we do not want to put burden on people. So we are very happy and very grateful that people did whatever they could, especially in some resource poor countries where they had to actually shift resources from something else because they believed in this. So we did not want to look a gift horse in the mouth. If they said 30 days, we said fine 30 days. If they said 90 days, we said fine 90 days. So we actually have an optional 90-day follow-up for people, but not all sites were told to do this. And the important thing here is, as you know, the natural history of cirrhosis after readmission is very much in 30-day intervals. So in 30 days, you get a lot of quote unquote, action. So it's not like a stable patient with outpatient with cirrhosis in which 30-day almost nothing happens. So we were fairly confident in the steering committee that this was a nice balance between lessening the load in the sites who may not have had resources to do this, and also getting enough valuable information. But that having been said, we have data for 90 days for selected sites also, but we are not doing it for 1 year.
Okay. And the other thing I just wanted to ask, because there was this component about the medications and the affordability, and a lot of this I think was based on the each site's investigators. Would there be an option of having the patient, or looking at the patient's, like some patient reported outcomes or patient reported kind of affordability of the medications? Because I think this is something that is more from the patient's perspective rather than the doctor's or the physician's perspective.
Yeah, that's a very important thing. And initially, when we had planned this study, we had not put that together. And this was a last minute thing that we realized, because the HIC and LMIC being different. So we had to go to so we are right now doing what we call the wave 2, because the other thing you realize that this was collected during the COVID pandemic. A majority of the sites were still suffering from COVID pandemic. So they actually had, even though we excluded people who either had exposure to COVID or were COVID positive during this hospitalization, there is a possibility that a lot of the ICU resources may already have been strained for the COVID positive patients even in high income sites. So what we are doing right now is a second wave from the same sites who did the first wave. And in addition to asking about what happens in I would say it's not going to be a COVID-free world ever, but where COVID hospitalizations have declined from the catastrophic levels to what they are right now, we are also adding what you said, a patient-level information for 7 or 8 specific interventions that we found had the potential to expose the most disparities. And some of them are medications, some of them are interventions, some of them are procedures, including, paracentesis, including things that we think are pretty basic. But in some sites, it's very hard to actually do. Or, of course, liver transplantation, it's a big, and then some medications such as terlipressin, rifaximin, intravenous albumin, and octreotide, etc., or the vasoactive agents to prevent variceal bleeding. So those are the treat variceal bleeding. Sorry. So those are the things that we are actually now doing it in a patient-by-patient perspective, which would give us a much more granular view than simply saying that because you are in a high-income country and 50% of your patients you assume are going to be able to afford, that may not be true for that patient. And a lot of other wrinkles have come up, like patients refusing treatment that we think is good. So it'll be interesting for us to know, and that would be a much more granular option.
Yeah, I think it's not just like financial, but also maybe cultural or social differences. Like, I think transplant in many different communities have different connotations. So like, for certain like Asian countries, like the idea of living donor liver transplant may be perhaps less palatable than, in Asia, in Europe or United States. Okay, so anyway, I just wanted to ask, I mean, given the results of your study, in terms of like, your study looked at the factors, that can affect what causes mortality on the index hospitalization and also at 30 days post-discharge. How do you think this can be applicable, like in terms of a clinical context, in terms of um, reducing mortality during inpatient admissions? I mean, what I wanted to say was something that, is translatable clinically for us, that as physicians, that we can apply. Is it to look at the infections, or what do you think we can do?
So a few things that are very important that jump out is to ensure that you know how much your patient can afford and what they can actually do. It's one thing to write a prescription and hand it to the patient, and if the patient cannot fill it out, and some of it may just be a lack of communication, and these are very important things. And instead of focusing on the hospitalization, because once the hospitalization happens, things kind of go on autopilot, whatever's available in that hospital, that protocol, it's very difficult to change. But I think the bigger focus here should be what happens peri-hospitalization and post-discharge, because that's when the opportunity comes. If someone is discharged from the hospital alive without a transplant, they have automatically declared themselves to be at a high risk for rehospitalization. And that's when I think a lot of our energy should be focused on to see why they're not taking the medications. What are the barriers? Could we have community resources? Is there a lack of education? Is there a lack of things that seem very boring, but they are the ones that actually yield results, these measures. They're not the shiny new medications, because it's the effectiveness of therapies rather than the efficacy that we are going for here. And in certain sites where there are just a lack of awareness about this is important, a paracentesis has to be done within 24 hours, or things like that, that you may need to actually communicate with people who are actually managing these patients after hours or during the hospitalization to improve outcomes. Whatever we found here was not rocket science at all. It was largely around what we had expected, but there were certain nuances about the inpatient care that was a reflection of outpatient care that to me was the most interesting. And that's where I think the biggest bang for our buck can be made by education and insights that are not as advanced, such as like Singapore, etc. Just the awareness of the liver disease being a huge burden on society as a whole. And in inpatient settings is an important thing for policymakers to put together to actually put more focus, because the liver is often not as, does not come as dramatically in the picture when it comes to public health. And I think we need to raise awareness of that as well.
Yeah, and I think with the, the increasing prevalence of NASH, with the obesity epidemic, this is something that is becoming more and more important. But I think you're right, still kind of not as well recognized by policymakers. I just wanted to, comment that I think you mentioned that the most important thing, or one of the most important things, is to look at the linkage between inpatient and outpatient care when the patient gets discharged, whether they are compliant, whether there's resources for follow-up, etc. In resource poor countries, it's great that we have identified these gaps and the fact that, the patients in these resource poorer countries lack access to important services. But I think although we have identified these gaps, it's challenging because resources are scarce. They need to be kind of rationed. And so if you were a policymaker, I know you're not, but what do you think in terms of access to care would be the most important things to institute? Transplant is obviously something that's important, but also extremely expensive. But more basic things, what do you think would be the most important things for a kind of developing country to focus on in terms of building their services?
I think education, not only of the patients and their family members, but the providers. And that does not have to be an MD or a doctor. It could be a nurse, it could be a paramedic, it could be anyone who the patients, developing countries have a huge success by, involving every part of the care ecosystem. And education that this person has liver cirrhosis and this could happen to them, and this did happen to them. And these are the signs when to bring them to the hospital. These are the signs, and access to medications. Some of these medications are relatively cheap. Again, I'm putting it in a context of a not a context of someone who has to run their household, but some of these medications, especially in some countries, are relatively cheap. But the important thing is to educate people that these medications are important to be taken and not stopped at the first sign of whatever. And again, this linkage of care could just be a human contact, as a phone call 4 days after her discharge. How are you doing? What a thing. And that phone call does not have to be someone from the hospital. It just has to be someone from the community or someone who's has some kind of medical knowledge for these patients. Those are very low income things. Like you said, the other extreme is liver transplant, requires a complete overhaul of the donation system, of the et cetera. And that takes a lot of work to do. And as you said, the obesity pandemic right now has everyone's some things in it, but the problem with the liver in that has to be highlighted also in what we thought were developing countries like India and China now are massive tips of the spear for MASLD. And some other countries in the Middle East who are not well developed or very well developed really carry a huge brunt of the obesity related illness. But it's the message related to the liver being a major player in that is still somewhat lost in between the cardiovascular complaints and the cancers, etc. So I think all of us in the liver disease community have to ensure that we raise our voices and make the policymakers know. Until then, these relatively low-cost options of actually following the guidances or guidelines as much as possible, making sure the patients have healthy diet, they abstain from alcohol. All these other things are really the most important things that will give you the biggest bang for your buck.
Okay. On that note, I think thank you very much. I think we have had a really productive kind of discussion on the article, and also on how we can help our patients or optimize the care in our liver patients with cirrhosis. So thanks a lot, Professor Bajaj, for your time today.
Thank you so much, Dr. Teng, and thank you to the Liver Foundation. And also, if someone wants to join this consortium, please email me at jasmohan.bajaj@vcuhealth.org. Thank you.
Thank you.
We have come to the end of the episode. Thank you for joining us and stay tuned for more captivating discussions.